Hi, everyone, and welcome back to Fit for Fellowship, a survival guide for the first year general cardiology fellow. I'm Megan.
And I'm Stacy.
And welcome back.
Today we have Dr. Stinis, who's going to answer the questions that we've received on his lecture on access complications. Dr. Stinis, thank you so much for being with us today and taking the time to not only teach us, but even kind of go through our questions.
Of course, my pleasure. Thanks for having me.
Great.
Excellent. So let's dive right in. So thank you again for going over access complications. And the first question is in regards to when you were pulling the arterial sheets, what is considered too dangerous to pull at bedside?
What is too dangerous to pull at bedside? That's a good question. In terms of, I'm guessing they're asking in terms of the French size of the sheath.
I believe so, probably.
Yeah, that's probably what they're asking. So that's a great question. So manual compression works very effectively for 4 French through about 10 French. So above 10 French, the risk of bleeding with just doing manual hold increases because the amount of time required to hold the vessel, is so long that people usually tire and they start to lay off pressure too quickly, or they're holding the artery occlusive for so long at that size of a hole that the artery gets a complication like a thrombosis or restriction in flow. So really, ideally, if it's over 10 French, it really should be closed with some sort of closure device or potentially surgically closed. But in terms of at bedside, when people have, say, for example, a balloon pump in place that's 8 French, that's definitely very doable. I would say my limit, especially for someone who's not that experienced, should be at most 10 French, but ideally probably 8 French is safe. Once you get more experience and your hand strength improves and you've got some technique down, you can probably do up to 10 French. I will say it also depends on the patient. So if the patient is thin and the site of access is in a good location over the pubis, chances are you're going to be able to get a good result. If the patient is obese, the artery is deeper, it's the location, of course, is not good, then that's a different story. So I would say, 8 French to 10 French would be kind of the upper limit, but I wouldn't go more than 10 French.
Makes sense. Thank you.
So the second question is, if the patient has a retroperitoneal bleed from femoral access and they just got a drug-eluting stent, what do I do about the DAPT?
Yeah, it's a great question. So if the patient has a retroperitoneal bleed, there's a hole in the artery that's bleeding there. And so what we need to do is seal that hole. And so that's why it's so important to get the patient back to the cath lab, find that hole, tamponade it off, and potentially put in a covered stent. If it is sealed off appropriately with a covered stent, there's no contraindication to DAPT. In fact, we want them on DAPT so the stent doesn't develop thrombus. So we don't want to interrupt, we don't want to interrupt that patient's DAPT because of the fresh stent. So it's okay to give protamine when someone has received a coronary stent recently, and that would reverse the anticoagulation like heparin, but it wouldn't, we don't want to give them platelets. That's the main thing. Okay. Because of course, when we give someone DAPT, we're inhibiting their platelets for, around 5 to 7 days until new platelets are formed. If you give somebody a bolus of new platelets, they will not be inhibited by the Plavix and they can go to the fresh stent and cause a thrombosis. So protamine is okay. Even FFP, if the patient is coagulopathic, those things are all okay. We really would like to avoid a platelet transfusion in that scenario because that's when you worry about a coronary stent thrombosis. But if the hole is definitively addressed with a covered stent or even with surgery, then you don't need to worry about interrupting DAPT.
Okay, thank you.
Excellent. So the next one goes back to the manual hold technique that you discussed.
Yep.
How do I know if I'm doing a good manual hold?
Yeah, it's a good question. So a good manual hold is a situation where there's no visible bleeding, there's no visible hematoma or tactile hematoma that's forming, and you have good control over the pulse and you can feel the pulse and you have good control over the artery. If you're sort of holding randomly and you don't feel the pulse and you see blood, you see a hematoma forming, then you're not doing a good manual hold and you're not under control. For the first 5 minutes or so, your pressure should be essentially totally occlusive. So what's also helpful is to have a nurse or an assistant Doppler the pulses in that leg and the foot. If there are no pulses, you're doing a good job. If you lay off your pressure a little bit and the pulses come back, then you know you're in the right place. Obviously, if there's no pulses and you've let off pressure and there's still no pulses, now you have a complication. So that's different.
Makes sense. Fantastic. Thank you, Dr. Stinis.
Okay, so next question is about an outpatient call. If a patient calls you and they're several days, maybe even a week out from the procedure, so it's not in the acute setting in the hospital, and they're coming to you with a hematoma, or they're saying, things are a little numb. What is sort of the sense of that threshold to say you have to come in? Do you still need to react the way you do several days in the outpatient setting and bring them in?
That's a great question. So it's not uncommon to get some phone calls from patients saying, I've got some soreness in my groin. So it's sometimes difficult to hash out, well, is this just a bruise? Is this just soreness? Or is this a serious complication? So there's a couple of things. You can ask the patient, to sort of feel their groin. Do you feel a lump there? If the lump in general is bigger than the size of their pinky nail, then that usually means that there's some sort of problem. A hematoma, a pseudoaneurysm, something like that. It's not uncommon to have a small lump from a closure device or some, local edema from a manual hold or something. But if it's bigger, I tell the patient if it's bigger than your pinky fingernail, there's something going on. If they have associated symptoms, numbness, tingling, difficulty walking because that leg is hurting them, color changes in their toes, other pain in the limb as a whole, those are all red flag warning signs that something's going on. So also in this day and age of social media and cameras, everyone has a camera phone. So sometimes I'll ask the patient, would you mind taking a discrete picture of just the femoral access site and sending it to me, electronically, so that I can get an idea of what we're dealing with. And if I see a giant hematoma, we got a problem. If it's just a little bruise, I can reassure them. But if there's any doubt or there's any associated symptoms like numbness, tingling, difficulty walking, color changes, coolness of the foot, anything like that, the patient should come in right away. And what I usually do is as soon as I hang up the phone with the patient, I will call our vascular lab and arrange for the patient to go straight there for an arterial ultrasound. And the ultrasound will tell us if there's a pseudoaneurysm, if there's a hematoma, if there's compromised flow in the arterial circulation of that leg, or if there's a DVT for some reason. That ultrasound will give me that information. So when the patient then comes to my office after leaving the vascular lab, I know if we've got an actual vascular issue. So that's kind of the way I would handle that. But have a low threshold if there are a lot of concerns besides just discomfort. Any of those other warning signs, have a low threshold to bring the patient in to be seen.
Okay.
Excellent. So our last question has to do again with retroperitoneal bleeding. And it sounds like the fellow was asking, what do you do if you're on the fence on whether it's an RP bleed or not? Like they don't quite meet the criteria for an RP bleed.
Yeah, that's a good question. So what I teach my fellows is if you think about an RP bleed, then treat it as such. So if they're acting hypotensive, if they look sick, they look unwell, if they're diaphoretic, if they're having back or flank pain, those are all warning signs. But again, looking at that femoral angiogram is very critical, because if the stick was clearly not high or not even close to being high, and there were no other warning signs on that angiogram, like laceration of an adjacent vessel or anything obvious, then it's it's more likely the patient may be suffering from something else, like a vasovagal reaction, or possibly a contrast reaction or tamponade or some other complication. So that's why I want to stress that looking at the femoral angiogram is so important. If you're able to read that, you have a good idea of where the stick was. If it was clearly high, then it's going to be an RP bleed. Nobody's ever going to fault you as a fellow if you took an RP bleed seriously, meaning you put in a central line, you gave them fluids, you put them in Trendelenburg, you called for blood, you maybe even given them a couple of units, and you tried to stabilize them. And then only to find out that they had some other problem. Nobody's going to fault you, but everybody will fault you if the patient expires or has, a really bad outcome because you missed a retroperitoneal bleed. There's really, there's this whole notion of, is there such a thing as a stable retroperitoneal bleed where it's so slow that we could send them to the CT scanner? In theory, yes. If they're that stable, you could send them to the CT scanner if you're not sure. But my point of my lecture is, if someone is unstable, they're actively sick, they're hypotensive, any way at all, do not send them to the scanner, because you don't need that to make the diagnosis, and it's not a therapy, and you're wasting time, and the patient could have a bad outcome. The other thing you could do, and we've done this before, is if you're still not sure, and they're acting like an RP bleed, is we simply bring them back to the cath lab and do an angiogram. If there's bleeding, we'll find it and we'll fix it. If there's no bleeding, we can reassure ourselves that that's not the diagnosis and it's something else.
Okay.
Excellent. Thank you very much, Dr. Stinis.
Of course.
I think that those are all of our questions. So
Very good.
that concludes our Q&A session.
Very good.
Thank you
Well,
so much. Yeah,
thanks again. Hopefully it was helpful.
definitely.
Definitely. Thank you again.
Thank you. Take care.